Bueno, buenas tardes a todos. Muchas gracias por acompañarnos en una nueva edición de nuestros Grand Rounds virtuales en medicina cardiovascular. Les recordamos que al conectarse a esta conferencia, autorizan el tratamiento de sus datos personales, los cuales serán tratados de acuerdo a la Ley 1581 de 2012 y nuestra política de datos personales, la cual pueden consultar en www.cardioinfantil.org. De igual forma, les informamos que esta conferencia está siendo grabada. El chat de preguntas se encuentra habilitado en la barra de participantes. Les agradecemos dejar allí sus inquietudes, las cuales resolveremos al final de la sesión. Hoy tenemos el gran honor de contar con la participación como expositora de la doctora Nadine Choueiter con la conferencia Utility of Multi-Modality Imaging for Diagnosis, Treatment and Follow-up of Patients with Aortic Coarctation. La doctora Nadine es originaria del Líbano, estudió medicina en la Universidad Americana en Beirut, posteriormente hizo su residencia de pediatría en UT Southwestern, cardiología pediátrica en la Universidad de Seattle y resonancia cardíaca en Boston Children's con Harvard Medical School. Actualmente la doctora es profesora asociada de pediatría en el Albert Einstein College of Medicine, asistente en pediatría de la División de Cardiología Pediátrica, directora de imagenología no invasiva cardíaca pediátrica y directora del programa de corazón fetal John Goodfriend en el Hospital de Niños de Montefiore. Bienvenida la doctora Nadine, es un honor contar con usted y esperamos tenerla personalmente pronto acá en Colombia.
El micrófono de la doctora está en silencio.
Nadine, your mic is off. You need to unmute it.
I think your microphone is off.
Okay, yes.
Yeah, perfect.
Okay, so I was saying thank you for the organizing committee for the invitation. I will spend the next hour talking about how all forms of imaging help us in diagnosis and in the management and follow-up of children and adults with coarctation. I will start with defining coarctation, what are the available imaging modalities, how we diagnose it, how do we proceed with management, and how do we proceed with follow-up. I have no disclosures other than discussing the off-label use of gadolinium, base contrast agent in children. So coarctation constitutes up to 7% of congenital heart disease, and it's in its simplest way is defined as narrowing of the aortic isthmus or aortic arch. And that's important because, as you can see on the images on the right-hand side, coarctation could be the juxtaductal discrete coarctation or narrowing of the aortic isthmus, often seen in adults, or it could be a tubular hypoplasia of the aortic isthmus and the aortic arch, which is the most common presentation in neonates. It's associated with bicuspid aortic valve in up to 60% of cases, subaortic stenosis, other left-sided lesions, VSD, left-sided SVC, and it's very important to think about Turner syndrome in girls diagnosed with coarctation because it can occur in 35%. Coarctation can occur in 35% of girls with Turner syndrome. So with the advances of congenital heart disease and with improved survival, we have had also advancement in imaging. We have several imaging modalities that allow non-invasive assessment of congenital heart disease. We have the echo that's readily available, often used in infants, and is non-invasive, does not require anesthesia, or often doesn't require anesthesia or radiation. But echo is often limited at times by suboptimal windows, and also sometimes the anatomy, especially the vascular anatomy, is not well seen on echo. Then we have cardiac MRI, which actually allows us to visualize the anatomy as well as the hemodynamics of a lesion. And it allows us to do that. It's almost a one-stop shop without the use of radiation. Yet it's not as readily available as echo. Experience in cardiac MRI and congenital heart disease is limited to a few centers. And in some cases, children will need anesthesia. And then we have cardiac CT, which actually has one of the best spatial resolutions of the three imaging modalities. It's fast and quick and does not require often anesthesia, yet it does expose the patient to radiation. And here are the things that we can actually see by echo, MRI, and CT, but essentially echo allows us visualization of anatomy and function. MRI allows us visualization of anatomy, function, and allows us to characterize tissue beyond the traditional evaluation of function. And cardiac CT is predominantly for evaluation of the three-dimensional relationship of structures. Often these are the extracardiac structures as opposed to intracardiac structures. Allows beautiful coronary artery imaging, and as I said, will not require anesthesia or sedation often. Yet it does not give us functional analysis. Diagnosis. So in terms of diagnosis, most of the diagnosis of coarctation is done postnatally. Prenatally, it's difficult to exclude a coarctation in the presence of a duct, and only less than a quarter of children with coarctation that will need neonatal intervention are diagnosed prenatally in the US. And also a third of those neonates with coarctation at times remain undiagnosed until after discharge from the newborn nursery. So our ability to diagnose coarctation is not the best. And that's why often in the US, what we require is what we call a congenital or a critical congenital heart disease screen, which is we measure oxygen saturations in the upper and lower parts of the body. And if there's any difference in the oxygen saturations, meaning the upper arm or the upper body is higher than the lower, then we often get an ultrasound to make sure this is not a critical coarctation. When we're trying to assess the extent of a coarctation and its severity, what we're looking at is to evaluate the arch in terms of where is the stenosis, how big is the stenosis, how wide, and what's the width and what's the length, and also what type of arch are we dealing with? Is it a left arch or a right arch? Then we have to look at the hemodynamic significance of the obstruction that we are having. And by non-invasive imaging, this could be done by measuring the peak velocity across the coarctation, by looking at the flow pattern in the descending aorta, looking for collaterals, seeing if there's any evidence of end organ damage, such as left ventricular hypertrophy, systolic dysfunction. And we also, clinically, we can look at the arm and leg blood pressures, because often a hemodynamically significant coarct would cause at least a 20 millimeter difference in the blood pressures with the arms higher than the legs. And then finally, we look for associated lesions, such as bicuspid aortic valve, sub-AS, or MS. And with bicuspid aortic valve, it's very important, obviously, to check for a dilated ascending aorta. So when we get a child with a suspected coarctation, they usually present in shock, or they present, as I mentioned, with a differential in oxygen saturation between the upper and lower part of the body, or a cuff blood pressure difference of more than 20 millimeters of mercury, or decreased femoral pulses with a cardiac murmur. And that's how we suspect a coarct. We get an ultrasound, and then we look at this ultrasound and we decide. So we get an echocardiogram and we decide, are we able to identify the anatomy of the arch and the physiologic significance of the coarctation? If it's a yes, then we stop there. But most often it's a no. And so we think, are we looking for more imaging to plan an intervention? At that time, we can consider a CT or a cardiac MR. In our institution, we often go for a CT in infants because it does not require anesthesia, and in young adults and older young teenagers and older adults, we go for MRI. Are we looking for anatomy and physiology? Often in an adult congenital heart disease population, our windows aren't the best in adults, so we often get an MRI. Is MRI contraindicated because of stents or metallic artifact? Then we go for a CT or a cath. And if we're obviously planning an intervention or we want to check hemodynamics invasively, then we go for a cath. I'm going to give you an example here. This is a 12-year-old patient who presented with hypertension and a 40 millimeter blood pressure difference between the arms and the legs. And so obviously we started with an echo. And what we see is we see an aortic arch that's, at least as far as what we can see from the arch, appears widely open. It's pulsatile. There's normal function. We look at the aortic arch. There's not much of a gradient by Doppler. We look at the abdominal aorta at the level of the diaphragm, and it's also not and it also does not show an obstructed pattern. So then we're trying to explain this 40 millimeter cuff blood pressure difference because it's real and the patient has decreased femoral pulses. We move further down on the abdominal aorta. This is a subcostal short axis. This is the liver, and this is the abdominal aorta. And this is the abdominal aorta beyond the diaphragm, so below the diaphragm. And we notice that there is flow acceleration there. And we notice that there's a peak pressure gradient of 36 millimeters of mercury. So the information did not really add up, and we were unable to evaluate this abdominal aorta beyond the liver. So in order to understand, we were suspecting, obviously, after this, an abdominal coarctation. In order to understand, or in order to evaluate this abdominal coarctation in terms of size and location and what intervention can we do, we went ahead and proceeded with a cardiac MRI. And this is the MRA. You could actually see that there is discrete narrowing of the abdominal aorta, and distal to the diaphragm and distal to the heart. And that's usually not where you see. This is a very rare form of a coarctation. Often, as I mentioned, the coarctation is juxtaductal. On this MIP, we actually wanted to also see what vessels were involved in this coarctation and the extent of this coarctation. What you see multiple intercostal collaterals and multiple vertebral collaterals, and you also see that the celiac trunk and the SMA take off from the descending aorta distal to this coarctation and are not involved in the coarctation. And that's important in case we decide to proceed with a stent, that the stent does not cover or does not obstruct the celiac and the SMA. So this is one example of how multimodality imaging helps in diagnosis. Moving on to repair. Often when we're thinking about repair or management, we're thinking about when we'll proceed with an intervention and how. In terms of when, in both neonates and adults, the timing of repair is closely related to the severity of the coarctation, so that the intervention is recommended if the gradient across the arch is more than 20 millimeter of mercury. The gold standard is the peak-to-peak by cath. We can also look at the Doppler echo and at cuff blood pressure measurement. And in case the gradient is less than 20, yet there is physiologic evidence of a coarctation, such as hypertension, left ventricular hypertrophy, or dysfunction, or an abnormal abdominal aortic flow pattern, or increased collateral flow, that's also an indication to repair. So we talked about how we assess the coarctation severity, And we're going to focus right now on the hemodynamic significance, since the severity really relates to the physiologic significance of this coarctation. And you can see that the first four factors, or the first four determinants of hemodynamic significance, can all be evaluated by imaging, whether it's the gradient, the flow pattern in the aorta, collaterals, and the presence of left ventricular hypertrophy and systolic dysfunction. So thinking about the pressure gradient, what we go by, as I mentioned, is that cath is our gold standard. And by cath, what we're measuring is a peak-to-peak gradient. So we're measuring the pressure in the before the coarct and the pressure after the coarct, and we're subtracting those. When we look at echo, often we're looking at the peak instantaneous gradient. So often echo overestimates the cath gradient, unless we account for the proximal acceleration in the arch. Then that correlates better with the cath gradient. And on top of that, that pressure gradient is definitely affected by the cardiac output and the collaterals. So if the cardiac output, if there is ventricular dysfunction, the gradient is going to be low. It's not going to be above 20 because there's not enough, the left ventricle is unable to pump enough cardiac output to generate such a blood pressure gradient. Also, in the presence of collaterals, the collaterals will bypass the obstruction and make the gradient look like it's lower than what it actually is. Looking at the abdominal aorta pattern, this on the left-hand side is a normal pattern with a normal upstroke, downstroke, and then there's a brief diastolic reversal with minimal flow during diastole. In coarctation, it's the opposite. You actually have a blunted upstroke and a delay in return to baseline. We call that a blunted abdominal aorta pattern. And people have looked at the rate of descent or the deceleration time, or either the deceleration time or the velocity of deceleration. Both of these are a marker of the diastolic tail. So this aspect of the flow during diastole as it descends. And various measures have shown that this diastolic tail correlates best with the coarct cath gradient of more than 20. So when you see an abdominal aorta pattern that looks that way, that is highly sensitive and specific for the presence of coarctation. And it actually normalizes after surgical or cath repair. So when we're evaluating the arch by echo or by MRI, we often not only look at how the arch looks, but we look at the flow in the abdominal aorta to see if we have a blunted pattern, and then we would be alarmed that this is actually a hemodynamically significant coarct. One of the things that people have looked at as well is combining the anatomy with the physiology. So combining how the arch looks with the flow pattern in the abdominal aorta. So Nielsen et al. took 30 children who've had MRIs and who have had caths within a year from each other, and divided them in those with coarctation gradients above 20 and those with coarctation gradients less than 20. And then they looked at the smallest dimension in the arch, the cross-sectional area of that smallest dimension in the arch. They took measurements from the ascending aorta all along into the descending aorta and through the arch, and they measured the smallest cross-sectional area. They also looked at several measures of acceleration and deceleration in the abdominal aorta. And what they found is that the index smallest cross-sectional area combined with the rate of deceleration across the abdominal aorta, those two put together have the best predictive value for a coarct gradient more than 20 millimeters of mercury. So they were combining those two together, predicted best the presence of a hemodynamically significant coarct. But as you can see, the numbers they measured were very very complicated and not something that we can use on a daily basis. So another group, what they did, they took this deceleration time. So the time from the peak flow all the way down to the to the lowest diastolic flow. They took this time called the diastolic time. And then they tried between the diastolic time and the cross-sectional area to come up with an algorithm that would predict a hemodynamically significant cohort. So they started with first looking at the cross-sectional area in centimeters square and normalized the body surface area. And if it was less than 0.33, they looked at 79 patients. They found that all of them had a hemodynamically significant cohort. They said, well, if the cross-sectional area is not that small, not less than 0.33, we're going to look at the deceleration time in the abdominal aorta. We're going to look at that flow pattern. And if it's more than 3 or more than 0.3, meaning that it's taking a longer time to come down to baseline, we're going to see how many of those have a cohort. And actually, the majority of them, so 30 of those, had a coarctation with a gradient more than 20, and 8 did not. And then they looked at if the deceleration time was less than 0.3, which is normal, and they found out that the majority of these patients actually did not have a coarctation. So combining those two parameters together, the cross-sectional area and the deceleration time, they found out that these two together have a sensitivity of 90% and a specificity of 76%, so slightly lower specificity in detecting a hemodynamically significant cohort. So how can we apply that to an everyday patient that we see? So this is a 4-year-old who presented with hypertension and a murmur. And what you're seeing here is a suprasternal image trying to connect the aortic arch with the descending aorta. I apologize. And what you can see is it's difficult to combine it because the arch is tortuous. And at the end, you see that also that there is turbulence within the aortic isthmus, such that we get a gradient of 50 millimeters of mercury, and that the descending aorta Doppler is quite abnormal and quite blunted. So obviously we knew that this was a coarctation, yet we were not sure of the anatomy of the arch, and we were not sure of whether this is something that's going to be amenable for surgical repair or for stent placement. So we went ahead and got a cardiac MRI, and you can see that the reason we weren't able to connect the arch to the descending aorta is because there's a severe coarctation. The isthmus measures 0.18 centimeters, and it gives the arch this 3-sign appearance, which is often seen in coarct. And you can actually see multiple collaterals coming off in order to bypass that coarctation. This is the flow pattern in the abdominal aorta by phased contrast mapping. So we measured the flow in the descending aorta by MRI, and we plotted that flow, and we can get similar to echo this pattern, and we can see how blunted it is with a delay in return to baseline. So when we took this isthmus measurement with a body surface area of 0.56 meters square, we got an index cross-sectional area of 0.32, which goes along with a significant cohort. When we looked at the delay time from the peak all the way down to the end, we found out that with a heart rate that when we normalized that to a heart rate of 90 beats per minute, that time was longer than 0.3 seconds. So both of these two parameters go along with a hemodynamically significant cohort, which is what the patient had. And this patient went ahead for an end-to-end anastomosis, or surgery with an extended end-to-end anastomosis. So what are the types of repair? How do we manage coarctation? We have surgery, and we have different types of surgeries. Often we have the end-to-end anastomosis, the extended end-to-end anastomosis, the subclavian flap repair, which often sacrifices the subclavian, and then the patch aortoplasty. The extended end-to-end anastomosis is the preferred surgery in neonates with a native coarctation, since it is associated with the least rates of, or the least rates of re-intervention, and need to re-intervene for a residual coarctation. The patch aortoplasty is also associated with a decreased rate for intervention, yet it does result in a higher rate of aneurysms in the arch. Stents, we can have stents in the aorta to repair coarctation, so this can be done via cath rather than surgery, and this is usually something that's reserved for adults and teenagers, since if we place a stent in neonates, it will not grow with them and it will need intervention. The other thing is balloon dilation, and often balloon dilation is reserved for recoarctation as opposed to native coarctation, since it is associated with a higher rates of aneurysms and also a higher rates of recoarctation. So for example, here we're going to take an example of a 2-month-old who presented in shock, and how did multimodality imaging help us with the repair of this lesion. So we can see this is a 2-month-old who presented in shock. We can actually see that there's a 3 sign to that arch. We can see that the arch itself is hypoplastic, and then there's a narrowing at the isthmus as well. Yet the flow acceleration or turbulence that we see by color Doppler is further distal to that. It's like right behind the left atrium. When we Doppler that, we only get a 14 millimeters of mercury, yet we know too that the function is down, so that we can't really rely on that gradient. And then the abdominal aorta pattern is not normal. It's definitely blunted. So, and this is the function. This is this patient presented with an ejection fraction of 30%, and in a 2-month-old, we expect the ejection fraction to be at least double that. So we went ahead, because this child was very sick, and we did not want to anesthetize the child, and we really were interested in the anatomy, and we had an idea of the hemodynamic significance since we already knew that this function was down, so we knew this was a hemodynamically significant cohort. We went ahead and got a CT scan, and what you can see from the CT is we have diffuse tubular hypoplasia of the arch with a severe discrete coarctation at the isthmus, further almost a centimeter below the takeoff of the left subclavian. So we were able to identify the location and the extent of the coarctation, and we were able to decide based on the CT that the best approach for this patient was to go for an extended end-to-end anastomosis. This is another patient. This is a 12-year-old who came to us, was morbidly obese, and came to us with hypertension. And we initially thought that the hypertension was related to lifestyle issues. Yet we know also that 12, in teenagers and in young children, we have to exclude other causes of hypertension. So what we see here from the suprasternal is we see the aortic arch, and then we see the color kind of become narrower. We see turbulence, but we don't see the arch past the isthmus. And what we also get is a peak gradient of 60 millimeters of mercury, and we get an abdominal aorta pattern that's definitely blunted. So we're thinking there is a coarctation there, but we can't see because of the patient's size, and the poor acoustic windows, we could not see the entire arch. So we got an MRI, and what we saw on this MRI is a very unusual anatomy. We saw what looked like a double aortic arch with a dominant right arch. We had 2 innominate arteries, and we had atresia of the left-sided arch. So there's no connection between the ascending aorta and the left outward aspect of the descending aorta. This is the, as it turns around, we will also see that we had coarctation in the dominant arch. We had a coarctation in the right arch. So based on this anatomy, we knew that this patient, we knew that this was a double aortic arch, so the arch was encircling the airway and the esophagus. So whatever intervention we do will affect the airways and the esophagus. We also knew that this was a morbidly obese patient who was very high risk to go under general anesthesia and undergo a cardiac bypass surgery. So what we did instead is we took the patient to the cath lab. We documented the presence of the coarctation by cath. You can see here it measures 8.8 millimeters. We placed a stent and we confirmed post-stent placement through bronchoscopy that we were not compressing the airway. So we can see how actually this multimodality imaging approach helped us in managing this patient and identifying the appropriate intervention for this patient. So in terms of surveillance and follow-up, what we know about coarctation, we know that the repair of a coarctation is a fix, but really not a cure. This graph here looks at survival of patients with coarctation in this non-bolded line, and compare it to the to age and gender matched population, and we find that the coarctation survival in coarctation patients is less than the general population. It decreases almost 13% per decade, and it's 74% at 30 years. And causes of mortality are coronary artery disease, mostly more than 30% of them experience a myocardial infarction secondary to atherosclerosis, sudden death, and heart failure. Also, we have an increased risk of stroke because of intracranial aneurysms. Up to 7% of it results in 7% of death in coarctation, and finally, ruptured aortic aneurysms. So the cause for this, the cause for these comorbidities that result in mortalities is really hypertension. Hypertension is the major culprit, and hypertension exists for several reasons, which one is vascular dysfunction. With coarctation, we have increased aortic stiffness, increased stiffness of the large vessels, and then reduced reactivity of the smaller vessels. Also, we see hypertension in those who have, it is very prevalent in those who were repaired at an older age, usually anyone repaired at an age older than 9 years. Hypertension can exist because of residual or recurrent coarctation, and also in patients with hypoplastic arch. The more hypoplastic the arch is, the higher the prevalence of hypertension. And that's why it's important not only to address the discrete stenosis, but the entire arch hypoplasia. And hypertension is responsible for the high rates of cardiovascular events such as coronary artery disease, sudden death, and failure of the left ventricle. Then we have stroke, which we discussed, which is secondary to intracranial aneurysms, and finally ruptured aneurysms, which is often seen in either it's procedure related, so often after balloon dilation of a coarctation, or in patients with bicuspid aortic valve. It's very important to follow up their ascending aorta dilation, because they can develop ascending aorta dilation that would require surgical intervention, or that might result in an aneurysm that will lead to rupture. How often do we follow these patients? So for adults, the American Heart Association has guidelines that base the follow-up the follow-up is really based on the physiologic state of the patient. So those who are asymptomatic or those who have mild symptoms and our New York Heart Association Class 1, we can get an echo every 2 years and an MR or a CT every 3 to 5 years. Similarly to those who are New York Heart Association Class 2. Those who are more symptomatic or who are in heart failure have to be seen yearly and have to be imaged anywhere between a year to 2 years. So echoes on a yearly basis and an MR or a CT on a 1 to 2 year basis. So this is a patient here who presented to us. This is a 39-year-old patient who presented to us from another country, who said that I had surgery in a different country when I was much younger, and he presented with uncontrolled hypertension. And when we looked at this patient's echo, we could actually see that we could see part of the arch. We couldn't see the rest of the arch. We couldn't really get a gradient across this arch. Again, the abdominal aorta was abnormal. We looked at the left ventricle. The function was normal, but there was left ventricular hypertrophy, so obviously evidence of end organ damage. So we went ahead and got a cardiac MR, and what you can see is a highly tortuous arch with several areas of obstruction. One before the takeoff of the left subclavian, one within what we thought was a graft, and a third one was between a graft and the descending aorta. So we thought this patient had a very rare form of an interposition graft repair. And what we also thought is that this was probably an interrupted aortic arch, as you can see here from the beak and in the descending aorta and the ascending aorta. This is a 3D rendering of that arch. So we took this patient to the cath lab to understand exactly where what the pressure gradients were at every parts of that obstruction to understand how to repair that. So what we see is that there was a 20 millimeter gradient before the takeoff of the left subclavian, a 5 millimeter gradient between the subclavian and the interposition graft, and another 5 between the graft and the descending aorta. And you can see here through this puff of contrast that this was really, that this is probably a severe interruption and a severe interruption of the arch. So the patient went ahead and so what we did is we took this patient to surgery and we placed a 20 millimeter graft between the ascending aorta and between the ascending and the descending aorta, bypassing this obstruction. This patient was discharged from the hospital within a week, and a year later, his blood pressure is controlled on only 1 antihypertensive as opposed to the 3 he was on before. This is another patient who came to us with coarctation after a balloon dilation. And we've been following her regularly, obviously by echo, but also with cross-sectional imaging, because this complication that you're going to see here, which is a large aneurysm in the descending aorta. This is something very difficult to see on echo and very difficult to see in adults with poor windows, especially after surgery. So you see this large aneurysm here. And so she underwent resection of that aneurysm and stent placement throughout the entire, she underwent stent placement throughout the entire arch, which you can see here by cath with in the cath lab. And then you can see how we don't see the aneurysm anymore, and we can see the stents covering the entire descending aorta. Finally, this is a patient who presented to us, who we've been following because of coarctation, and who also has a bicuspid aortic valve, and presented to us in chest pain. And on echo, his ascending aorta was found to be 5.6 centimeters, and his aortic valve was calcified. He had at least moderate stenosis, and so based on these two findings, he actually underwent a cath. We made sure his coronaries were okay given his age and presentation. And then we also did a CT scan to see the extent of the dilation in the ascending aorta. You can see how he has a tortuous arch with a very acute angle. Yet when we cast the patient, there wasn't much of a gradient, but the ascending aorta was severely dilated, very similar to what we saw on echo. We didn't see any other additional aneurysms. So this patient went for an aortic valve replacement and also a replacement of the ascending aorta with a graft. So these examples show how we have used multi-modality imaging in diagnosing in diagnosing, managing, and following patients. And yet, one thing to remember is it's not just about the heart. We have to remember the brain. One of the things that we look for is, as I said, intracranial aneurysms, because 10% of cohorts have intracranial aneurysm by the time they're middle age, they're in their 30s. One study, it's a national based study that compares all patients who were hospitalized with stroke and divided them into those with coarctation and those without a coarctation. And we found that the risk of stroke in those with coarct was at a much younger age, as young as 16 years of age for hemorrhagic stroke. And we found also, the study found that there was a higher rate of hemorrhagic subarachnoid hemorrhages and hemorrhagic stroke in patients with coarctation as opposed to no coarctation, almost, up to 12%. So there's definitely a higher incidence in patients with coarctation to develop aneurysms and to develop stroke, much higher than the general population. So thank you, and I'm open to answer any questions.
Thank you very much, Nadine, for this wonderful presentation. Very interesting and a very interesting topic that we see probably every day in our patients. I have a couple of questions of my own, and then we'll go with questions from the audience. Can you hear me?
Hello?
Yes, can you hear me, Nadine?
Thank you for your attention, and I'm happy to answer any questions. Hello?
Okay, can you hear me?
Yes, can you hear us? Were you able to hear me this whole time?
Yes, perfect.
Oh, good. Okay, good.
So I was saying that thank you for this wonderful presentation, very interesting topic, and probably something that we see every day in our patients. I have a couple of questions, and then we'll go with questions from the audience. As you were saying, the guidelines say that the patients should go for an image to evaluate the repair site after a coarctation repair every probably 1 to 2 years, depending on the functional class, or 2 to 5 years.
Yeah.
What would be the best image to control these patients? It's either GE or CT, MRI.
I think so. It depends on the age of the patient and their level of cooperation. I would say if we're surveying, and also what we're looking for. In terms of, I think, given how readily available echo is and how great of a screening tool is, I would definitely start with an echo, because on the echo we can check, maybe you won't, even if you don't see the arch, you can look at your abdominal aorta, you can look at function, you can look at left ventricular hypertrophy if it's present. I think also, and then I would move over to cross-sectional imaging, either if I see anything concerning or on echo, or if the patient is at risk. For example, it's a bicuspid aortic valve and the ascending aorta is dilated, I would definitely proceed to cross-sectional imaging. If it's a surveillance study and it's a regular follow-up study, I would do an MRI as long as the patient can tolerate the scan without the need for sedation or anesthesia. If it's someone who's, if it's a study that's being done on an urgent basis, for example, like our patient who came in with chest pain and there was concern for a dissection at the time, definitely I would do a CT scan. So I think we have to tailor it to the patient's age, the questions that's being asked, and the patient's state at the time the study is being done. But definitely start with an echo and then proceed to either an MR or a CT if there's a question that has been unanswered by echo, or if the patient is at risk for developing either aneurysm or concern for recoarctation. That's how I would proceed.
Perfect. And do you think this image should include any anatomical study of the intracranial vessels, given the fact that we have a very high incidence of intracranial hemorrhage.
Yes, we have to screen. So the study that I showed you is by Picard et al. She had another. There is another poster that hasn't been published yet about screening and the need to screen early, and that's because they develop those intracranial aneurysms as early as 16 years of age, especially the hemorrhagic and also subarachnoid hemorrhages as early as 15 to 16 years of age. So it's very important to scan the brain and to start early. And often what we do at Monte is when we have a teenager going for a follow-up MRI or a surveillance MRI, cardiac MRI, we schedule one for the brain as well.
Excellent. There's a question from one of our surgeons in the audience. He's asking about a very interesting topic, and is hypoplastic aortic arch. Sometimes it's not very easy to diagnose the hypoplastic arch, even in neonates. What do you think which one would be the best modality to diagnose this?
So in neonates, we usually, in neonates, the echo shows us at least the arch. We can see the arch and the transverse arch much better than we see it in adults, and we reserve to that as our primary imaging modality. And we measure the arch and we normalize it to body surface area, and we use what we call z-scores, or how many standard deviation from the mean it is. And if it's mildly hypoplastic, so if it's only somewhere between 2 to 3 standard deviations lower than the mean, then our surgeons do not intervene on. But when it's more than 3 to 4 standard deviations from the mean, that's when they actually consider end-to-end anastomosis. Now, if we're unable to see the arch in a neonate, and we're unable to evaluate the hypoplasia on the echo, we proceed for a CT scan, and that practice has changed. In the beginning, we were doing MRIs, but the quality of our CTs and the new generation of CT scanners give us really good spatial resolution. So we go with that.
Perfect. And do you think the shape of the arch can predict the presence of systemic hypertension in the future, or a high risk of recoarctation?
It's there's a study that found that actually the degree of hypoplasia of the aortic arch, the more hypoplastic it is, the more hypertensive these children are. In terms of the geometry of the arch per se, not necessarily. The geometry might make the repair may be more difficult, but not necessarily predict coarctation and predict hypertension in the future. But definitely the degree of hypoplasia of the arch has been found to predict hypertension, or to be associated with hypertension.
Okay, Hector is asking a couple of questions. Would you do a CT or MRI on every bicuspid aortic valve patient, at least once, to make sure the low sensibility of TTE does not miss an aortic coarctation?
For coarctation, so if we have a bicuspid, so obviously if this was a child and we had a bicuspid aortic valve, we look for other left-sided lesions and we look for a coarctation. And what we do is we look at our blood pressures. If our blood pressures are normal, and our abdominal aorta is normal and the arch looks normal, measures normal on echo, we do not proceed further. In adults, we do almost the same thing. We look at the arch. If our abdominal aorta is normal, and if our blood pressures in the upper and lower parts of the body are normal, and if our femoral pulses are normal, we don't proceed further. Yet that's one thing we talk to our adult colleagues about, is when they see a bicuspid aortic valve patient for the first time, to get blood pressures in the upper and lower extremities and to document their femoral pulses. And we look at the abdominal aorta in these patients by echo, in case we're not able to see the arch and we're not able to get a gradient across it.
Perfect. We have one question of one of the cardiologists in our team. Do you think a CT is necessary in every patient with an aortic coarctation? I think I assume we are speaking not about neonates.
Okay, so I think the older we get, the more we rely on cross-sectional imaging, and when we're trying to decide whether it's surgery versus the older we get too, we have more options. So it becomes that, do we stent the coarct or do we do surgery? And so in that case, you will need cross-sectional imaging. And what type of cross-sectional imaging, whether you do an MR or a CT, depends on what more questions do you want to answer. Do you want to look at the hemodynamic significance of that coarct? So then you would get an MR. If it's only for anatomy, you would get a CT. And also it depends on the surgeon's preference. So a lot of the times it's a discussion with the surgeon about which imaging modality they would prefer. Yet I would say the older the patient gets, the more we're going to rely on cross-sectional imaging before we send the patient to a procedure. Unless you decide to do a cath because you were going to do that, you want to check the pressure gradient, and then you don't need MR or CT.
Okay, another question would be, in case we have a patient with a peak-to-peak gradient higher than 20, with severe aortic regurgitation with a bicuspid aortic valve, what would you do first? Would you fix the aortic coarctation first, then the valve? How long would you wait to see changes in the regurg?
It has been our experience that if we think that the valve needs to be operated, so if the valve needs indications for surgery, we would do both, the valve and the arch, because we have not seen, you said severe regurgitation or moderate regurgitation, right?
Severe.
Yes. So we haven't seen that much improvement in the degree of regurgitation just by decreasing the afterload from fixing the coarctation. So we don't want to go in twice on that patient.
So would you do the whole repair, surgical repair, even if it's an adult patient?
If it's an adult patient and this patient can have a stent, you probably would start with a stent to look at you can fix the arch with a stent and then proceed surgically on the aorta.
And how long would you wait to do the second procedure? Would you do it in one single anesthesia time, or would you wait a couple of months, or what's the preference?
I think it's going to have to be a decision between how comfortable the surgeon is going in after a stent placement. I think I would wait a few weeks because you want also that stent to heal before you go ahead and then submit them to another surgery, which is going to be to another procedure, which is going to be a cardiac surgery.
Okay, perfect. There's another.
What has been the experience in your center? What would you do?
Actually, we are doing a paper about this kind of patients. Mm-hmm. We have, I'm not sure about the number, but I think we have 15 or 16 patients with aortic regurg, severe aortic regurg with coarctation. Mm-hmm. And one of them was an aortic dissection with coarctation. Mm-hmm. And we usually put a stent on the coarctation, and then we wait a couple of weeks to see how the heart behaves and how the valve behaves before going for the second time.
Okay, and what have you found? I'm just interested because we haven't found any significant improvement that would tell us we don't have to proceed.
Yes, we haven't. What we have found is that the aortic regurgitation stays probably severe, but the function of the heart goes or improves a lot.
Yes,
actually,
exactly.
A couple of weeks ago, we had a patient with probably 20% ejection fraction. We did the coarctation dilatation with a stent, and we operated on the patient, I think 1 or 2 days ago, and the ejection fraction went from 20 to 35 or 40%.
Yeah, okay.
There's another question from one of our cardiologist who is currently doing adults with cardiopathies, with congenital cardiopathies in Canada. He's asking, in the evaluation of collaterals, what is the cutoff point in terms of percentage of collaterals to intervene the patient with coarctation?
Yeah, that's a very good question. So I didn't actually address that for one reason, is that in terms of collateral flow, the way we measure collateral flow, and especially on cardiac MR, is very much dependent on measuring flow before and after the coarctation, which is very much affected by the fact that we have a coarctation. So often those numbers are not very accurate. So we usually don't use collateral flow in our decision making. For aortic arch repair. I know other centers use it, and they use anywhere between 20 to 50% to decide something needs to be repaired or not. We don't usually use that because we have found it very unreliable.
Okay, I'm going to do one more question, and then I'm going to give Hector the word. If we think there's a problem with the stent, maybe a fracture of the stent, what would you think the best image to address this would be?
That's it. So if I mean, and how did you suspect that, on a chest X-ray?
Yes.
Okay, so I think for stents, I think the best thing would be if you want to do it non-invasively on a CT scan, and if you have a very strong suspicion that the stent is fractured and you think you want to intervene on that, then and you think you can do it in the cath lab, then going for a cardiac catheterization would be the second best option.
Would you go straight for the cath?
You go straight for the cath.
Okay, I think Hector wanted to speak.
Nadine, thanks so much for your conference. It was really, really nice, and I love the images. Just a question with Julian, who's my radiology colleague who works here in our imaging center. As we mentioned on SCMR, we had the chance to look at the CT revolution from GE at the Force, and at the Toshiba Killian 1, and they're extremely impressive. You know, they've been out there almost 5 years or more. And Andrew Powell was having a lot of fun with the Force. We're a little bit in shock that, you know, one of the godfathers in the world, your mentor, was having so much fun and was almost, you know, changing techniques to look at congenital heart disease. Do you think with the extreme low radiation doses that these scanners provide, do you think MR is needed any longer to look at the aorta, or we can just follow the severity of the AI and a bicuspid with an echo and just do CTs regularly on these patients, assuming we use a 70 kV radiation dose from the tube current, and we're very cautious about, you know, keeping the MAs down and the whole millisievert exposure down. Okay,
and you're talking about adults, right?
Actually, both. I mean, for kids as well.
We're using more CTs. We're using, I would say, since the emergence of the new CT scanners and the new generation CT scanners, we have moved. So if our question is only anatomy, which is often the case in kids because echo provides us good windows, then we are using more CT scans for evaluation of anatomy. It's faster, great spatial resolution, and low radiation dose. In adults, I would say I'm going to talk about adults with congenital heart disease. Again, if it's only we're interested in anatomy, and because if we're interested in degree of regurgitation, or we're interested in evaluating the hemodynamic significance of something, we go for an MR. But if it's only anatomy, we go for a CT scan. Because the thing is, relying only on echo, like let's say if you have an adult, relying only on echo to quantify the degree of aortic regurgitation might be difficult, because It could be an eccentric jet, especially with bicuspid aortic valve. So some of the markers that you use, or some of the numbers that you use, might not work for that. With congenital heart disease, you can have multi-level or more than one valve disease, or multi-level obstruction if you're evaluating for obstruction. So you can't really use the numbers you get by echo to quantify the severity of whether it's regurgitation or stenosis. Yes, I do those see, and I know, like, I trained in Boston and we were heavily MRI based, but we have, even at Boston, they have moved into doing more CT scans to evaluate anatomy and vascular relationship, the relationship of vascular structures.
Thank you, Nadine.
I think we have time for last two questions. One question from the head of our department, or radiology department. To assess the hypoplastic aortic arch, what values do you use? You use set scores? Do you have any calculator or any web page to use to calculate this?
Yes, we use Z-scores, and I'm laughing because we use the Boston Z-scores, which obviously are unpublished, and they're on the Boston Z-score calculator webpage. There are different calculators, and it's interesting because different calculators give you different answers. Yet, the reason we use Boston Z-scores is because some of the data that came out of Boston using those Z-scores. So we have some outcome data using Boston Z-scores. And I'm talking about Z-scores on echo. You're talking about radiology, right? You're talking about MRs and CTs. That becomes much more difficult because with the studies that evaluate normal values are very limited, very small number, and they give you different values. So it becomes really tough. So what we actually do is, if we're evaluating an arch, we look at the measurement that we have and we compare it to, so we look not just at the absolute measurement, but we compare it relative to the descending aorta, and relative to the arch, and relative to the ascending aorta. So if I have an ascending aorta of, let's say, 2.5 centimeter, and then my, so let's say I have an ascending aorta of 2.5, and then my arch is 1, then I know it's hypoplastic. I would probably call it moderate. Yeah, but to make a long story short, normative values using MRI in children is tough. There is data out there through the SCMR articles on normative values in adults, and in adults it's much easier. We use Al-Faqih et al., which is 2003, published in 2003, and we compare to the mean, and we say anywhere between 2 to 4 standard deviation from the mean is considered mild, 4 to 6 is moderate, and more than 6 is severe. And this is completely made up.
Perfect. And I think the last questions come from me would be, do you think there's any place for 3D printed models in this type of patients?
Yes, definitely there's a room for 3D printing model. We did not have a case where we used 3D printing, but I know others have used it in order to determine, especially for interventions, to see if the size of the stent, where would the stent go, for simulations, and to see if to prepare more for interventional planning. But definitely there is room for 3D printing.
Okay, thank you very much, Nadine, for this wonderful talk and these interesting answers. I don't know if Hector wants to say something.
No, thank you so much, Nadine. Thank you, Tomas, for moderating. It's great to see you again. I'm happy New York is getting better with the COVID. And thank you. That the images were great, and I think you answer a lot of the questions that we have on a daily basis. And hopefully we can work collaboratively with our center, because we're busy. We're very, very busy. They're probably one of the busiest centers in Latin America. So So I think there's a lot of room for getting things together and publishing with our heart team for Peds.
Anytime.
Great.
Thank you.
Thank you, Nadine.
Okay.
Bye-bye.
Bye-bye.